All right, everyone. Thank you for joining us for our Urgent Care Center staff meeting today. So we're going to two things we're going to talk about. We're going to talk about our out-of-network workflow update and also about ED transfers. So going to move forward and let's do our land acknowledgement. We would like to acknowledge the Ramaytush Ohlone people who are the traditional custodians of this land. We pay our respects to the Ramaytush Ohlone elders, past, present, and future, who call this place a land that ZSFG and UCSF sit upon their home. We are proud to continue their tradition of coming together and growing as a community. And we thank the Ramaytush Ohlone community for their stewardship and support, and we look forward to strengthening our ties as we continue our relationship of mutual respect and understanding. All right, so let's get started. So we're going to talk about kind of an update about our out-of-network workflow that we've been doing, I think, since April, beginning of April, where again, just as a reminder, we are trying to really preserve our capacity for our in-network patients and for our uninsured patients of San Francisco County, and trying to get people who are out of network to their correct network so they can receive the appropriate care that they need. So just wanted to review again, and this is some of the data that Amy has shared, but really our out-of-network patients make up 17% of our total urgent care visits. That's quite a bit as far as taking, our resources and for people who actually have resources designated elsewhere. And again, one of the big goals is that we are aligning with not only our hospitals, but also the health network's True North goal, financial stewardship, as well as quality of care too, and care experience. And the idea is really we want to be able to expedite out-of-network patients to get where they need to go, which is their in-network primary care medical homes. Our hope is also to streamline the process. So you all know we have a workflow for transferring patients to their on-campus primary care clinics like RFPC or FHC or Positive Health Program, or even the Children's Clinic, Children's Health Center. And so our hope is to try to streamline this process as well, so that people, we all kind of know what we need to do. We do it in an expedited fashion. And then the last goal was interesting, is kind of the why didn't we do this earlier? And this is kind of alluding to a story that she was shared with us, where a patient came in February. This is before out of network process. And she was out of network, but she was seen in the clinic and such. And then what she did is she ended up referring one of her friends to come to urgent care in like April. And that friend was actually out of network and was able to experience our out of network workflow. Later, we find out that the original person that came in February got a bill and was, of course, not happy, right? Because we were out of network, and was asking, why didn't we do this sooner, right? Why didn't we do this earlier so that she wouldn't have to get an unexpected bill? And so again, that's one of our kind of stories that we keep with us. Is like, we want to have a better experience for our patients as well, even if they're out of network. People who come with, we want to be able to give them the right, guidance and advice about how to seek healthcare. So our countermeasures, as you know, Amy and New worked extremely hard, and Merjo worked extremely hard on this out-of-network matrix, which has really been awesome. It covers most of our out-of-network designations. It's not all, and some of them we still have to figure out, and it's been updated constantly, which is really wonderful. And they've also provided this alternate care list, which I think is hugely important, that once we, inform a patient that they're out of network, that they have a place where they can go. And it's not just, you're out of network, goodbye, you figure it out. So I think that's really a wonderful thing that we've been able to do. And again, thanking Amy, New, and Merjo for that. We meet weekly with the patient access leadership team to make sure we continue to refine this process. And then, we had received feedback from all of you. And, at first, I think everybody was kind of like, yes, this is great. This makes sense. This is meaningful. And then we realized that there are some difficulties with things. And so we started to trial this MSE team, PDSA, where we would have a designated team kind of managing the out-of-network patients and being able to kind of get them through faster in the urgent care. So that's something that we're going to talk about in a little bit. And then also what we've been doing is trying to address issues reported by the charge nurse and everybody else in real time.
With the card and your hands up.
so we can make kind of, in the moment improvements and go from there. So those have been our countermeasures as of late. And just talking more about the MSE Team PDSA. Again, like I said, a designated team to really improve the workflow. We started this in April 29th, and this is based on all your feedback. And again, the team is assigned not only the out-of-network patients, but also non-urgent complaints so that they can prioritize expediting these out-of-network patients to their urgent care clinic. And so just wanted to show you the graph on the right side, is that, our baseline prior to this PDSA, our average lead time was about 80 minutes. And so this, by the way, also, we took out the nursing visits and the outliers just to kind of get a little bit of better average. Now, when we started out-of-network workflow in April, it actually, the lead time overall went down to 62, which is pretty impressive. And when we started the MSE Team PDSA at the end of April, and I believe Amy collected data for about a couple of weeks, our lead time actually went down even more to 51. So what does that mean? Like, lead time is the time between check-in and check-out. And again, the idea is that if we can get patients in and out in a appropriate, clinical fashion in a timely manner, then we leave more capacity for ourselves to see patients, right? So hopefully this is also an indicator of improving not only our access, capacity, and just flow in general. So this is great news. We'll keep following up with this data. So successes, right? I think that I've been able to talk to some of the MSE team providers. I had the pleasure of being one this week or last week. It was this week. And, I think I kind of agree that the process has been fairly smooth. I think there's an understanding of this is the person's role for the day, and it's been a really smooth process. Expediting visits has really been helpful for these patients. And a lot of times they're thankful for letting them know where they need to go. Yes, some of them are a little bit irritated, and understandably so. They expected that they would be able to get care here, and they realized that they were out of network. And we've also had less patient complaints. So I think that's really helpful, again, talking about care experience for our patients and quality. Now, the challenges, of course, again, it's a little balancing act, right? Because if you're an MSE provider, MSE team, and you get a patient that needs a little bit more time and evaluation, that might take away from then an out-of-network patient that comes in, and then you've got to juggle the two. And you really want to expedite the out-of-network, but maybe this other person needs more attention more immediately. So again, it's balancing that schedule is sometimes a challenge. And of course, staff shortages, right? So what we're trying to do is cover the whole clinic open hour time with an MSE team. And so if we have shortages, obviously that provides a little bit of a challenge. And then of course, there are times where if the out-of-network patient is waiting longer, I think we realize the longer they wait, that the chances of them getting upset or irritated gets higher, and that makes sense, right? So again, it's trying to expedite those visits. So anyway, I know there's some comments in the chat. Sorry, we'll take a look at it, but we're gonna, if you can, again, hold your questions till the end, and then, or comments or concerns, we'll provide that time for that.
Carmen, I think,
oh, go
Carmen,
ahead.
Before we move to, we can probably address it since we're shifting topics. So I think Megan had some comments about the flyers not being updated, needing more updates. So that is one of the challenges. I think if everyone can remember how many versions we've created. So it is a very complex process when we talk about insurances and the contracts and the many different stakeholders that are involved. And if you can imagine, when you look on the internet, even when you look at flyers that you've ever received, a lot of them will already be outdated by the time they're posted. So because it's a challenge to keep things updated on the internet, on the online information as things change, contracts change in the middle of the year. So we just want to let everybody know that Amy and New have actually been really working very hard, and we are involving all of the right stakeholders in the hopes that the information that we give out to all of you is the most updated that we can get. But again, you will see errors in there, and that is one of the reasons that you're constantly seeing different types of updates, almost like on a weekly basis, if you remember from the start. But it is super helpful when you guys bring to our attention, especially things that are not, maybe we may have missed, or maybe, you know, some of the things that you're seeing on a regular basis, because we may have opted to take that off of the list because we're trying to come up with a one-pager, which is, you know, even more challenging. But we will do the best that we can. So for the folks that see that something needs to be added, I think San Mateo, we will definitely take that into consideration and look at that for the next iteration.
Thank you, Merjo. The other thing too, I forgot to mention, one of the countermeasures that we did try as of late, and this is thank you to Brooke for suggesting it, is that incorporated into the discharge smart phrase are a list of, I think, the SFHN and the consortium clinic addresses and phone numbers, so that if you want them to follow their PCP, and again, it's like, well, who's my PCP, right? You can actually have a drop-down list and include that, at least the address, the name, and the phone number. And actually, yeah, Megan, if you have a list of the out-of-county, we could also incorporate those lists into the discharge paperwork, so that, you know, again, we at least have a place that we can give them that information. So that would be wonderful if you could share. And then, of course, let me know how that smart phrase is doing for all of you. I've added to the telephone encounter smart phrase as well. Could do with a little improvement on that one though, but let me know. So still we're trying all these things to see if they help. And again, don't hesitate to give us feedback. Maybe something's not working. Okay, let's try to continue to refine the process. So appreciate all your input and feedback on these things.
So the comments, I think I want to make sure people are aware. People are asking if they can refer patients back to their insurance. Absolutely, Tanya responded to that, and Melissa mentioned if patients have questions, they should refer back to eligibility, and that's correct. That's part of our standard workflow, and should be part of our script. That if patients, after you've told them you're MSEing them to their network, they feel like they have more questions about their insurance and et cetera, that is not something, even though you guys have a lot of awareness on the out of network handout, our expectation absolutely is not that you have this knowledge. We have a whole team that we hire, and that is the eligibility team, to be able to speak to that type of language. Does that make sense? I know you guys, a lot of you are now much more versed than many different caregivers that I know in the healthcare system, just because of the amount of discussions that we've had on this. But it is still not an expectation for any of you to be able to say, yes, Blue Shield Blue Cross, you're out of network, please refer them back to eligibility. And that's why our script specifically says, if you have further questions, I can have someone talk to you. Does that make sense? Mm-hmm. Okay. Any other questions from our group? Okay, so I think we can move on to the next topic. Did you want me to move the slides? Oh, okay.
Yeah, I get it. Just let me know when the next slide, please. Yeah. Perfect.
Okay. So the next topic that we're going to be talking about is slightly connected to this, but we're going to just do a review of our emergency department transfers. As we mentioned in huddles this week, in the last few weeks, we're seeing a lot more issues again between our two departments. Not that we didn't before, but it seems to be ticking up a little bit. So we want to just do an overall review and just remind everybody about some of the goals and some of the possibly inform you about some initiatives that are kind of in the forefront that have caused some of these issues and questions. Next slide, please. So again, just a little bit of history. The ED and the urgent care have had a very strong partnership. And I think for those of you that were here when we moved, that partnership strengthened even more when we moved to this building, because it made our proximity even closer. And our ability to collaborate much better. And in fact, for those of you that were in the brick building, you remember our volumes used to be like in the 70s, would be like a really high number. And the ED transfers were probably non-existent, to be honest. And when we moved here, those numbers jumped as far as the number of patients that we saw. But the ED to urgent care and transfers also jumped. And if you guys remember, because you were involved in this PDSA before I even started, there has always been a big initiative to be able to send lower acuity patients from the ED to urgent care. And you guys did a lot of PDSAs around this even before we moved to this building. And there was a goal to get that to about 600 patients in a month, because that was the need for the flow of the whole campus. We were able to probably push that up closer to goal when we moved here, because a lot of the work that we did before the pandemic on efficiencies and reducing holding to the ED really kicked in, and we were able to really create workflows between our departments to streamline the process better. And the pandemic made this even more feasible, and really just made it more seamless, because we added the lobby team that really helped triage and create quality checks for patients that are walking in on campus, as well as patients that are coming from the ED, for us to ensure that they're safe, that they're meeting our exclusion criteria, and that we are also sending patients to the ED correctly, because we have clinical staff that are in the lobby doing triaging. So I think the reason we want to remind everyone about that is part of the reason, and a large part of the reason, that we have been allocated a large number of staff since the pandemic is truly because we were able to demonstrate that the staffing for the lobby and the additional providers, and in order to meet the metric of meeting the goal, the number of patients that are now coming into urgent care, was a true valuable effort, and that it does in fact contribute to reducing the flow of patients into the ED. The metrics that we look at to show this is the fourth and fifth tier patients in the ED have greatly reduced since we've increased the number of patients that are transferred from the ED over here. So we meet with the leadership team on a monthly basis to discuss issues and concerns and ensure that the pathways are smooth. But for those of you that are trained in the lobby and the charge nurses that are working very closely on this, you know all the efforts and the work that we are doing with the ED team. And again, next slide, please, Carmen. Want to really show you guys that a lot of the efforts that we are doing are being seen by our administration, by our leadership team. And Teresa can speak to some of that, because she hears a lot of how essential urgent care is to the overall flow on campus. So ED transfers, like I mentioned, is one of probably the biggest metrics that the whole campus looks at.
Us to them.
Us to them,
Okay.
Correct. I'm sorry.
No.
Them to us, and they will also look at us to them, because that is one of the things that they.
So by direct.
Correct. And so for those of you that aren't aware, our ED metrics actually gets reported not only to the daily bed meeting, which is why, you know, the lobby team on a daily basis send me logs before by the end of the shift. I send those, in addition to the charge nurses, to the bed meeting on a daily basis, because the AODs have to be able to account for, are we able to support flow in the campus today? This report gets sent to our admin executive team on a daily basis, on a weekly basis, and the report also gets transferred and sent to JCC in order to report to the Health Commission on a monthly basis. So that is how we were able to and have been able to advocate for right-sized staffing for urgent care. We've been able to advocate for all of the, then I think at this point, we've already received, 14 NP as needed per diem positions. We've received about 20 plus, RN per diem positions. And we've been able to create a budget plan to advocate for permanent staffing for those positions that we've been getting as per diem. Does that make sense? So that there is a measurable data that we have been able to show for the last many years since the pandemic to be able to justify that. So because it is such a highly scrutinized and reviewed metric, there has been an increasing urgent care to ED increase that was noticed in January of 2024. So again, we look at this very closely, and in the last 8 months, when things increase, as a leadership team, we normally will go, maybe that's an anomaly. If it continues on for a few more months, then it's no longer an anomaly, right? It's obviously a trend. And so just be aware that the urgent care to ED transfers have been increasing in the last eight months, actually. We in addition to that, as you guys are aware, the ED has gotten even more pressure about their diversion rates because of a recent report. I want to say it was back in the fall of 2023, where they were looking at their left without being seen rates, and it was determined that it was probably one of the lowest rates in the nation. And that's where you guys heard that we've started helping with some of the triage project, just to really look at how to streamline their ability to MSE their patients in their waiting room much faster. In addition, we know that staffing shortages have continued to impact the entire San Francisco health network, as well as the nation. And Teresa is here again to speak to some of the many challenges that we've actually determined on our own, as well as in reading the literature, that a lot of the EDs and urgent care centers have really been impacted since the pandemic, because not only have so many healthcare providers and staff left healthcare because of, whatever, the pandemic pushed them off the edge or something. But we also know that primary care has absolutely been impacted by those staffing losses, by just the amount of work that was pushed back and then added on since the pandemic. The severity of the illness of patients that are coming in, we know even for ourselves, has really just been more challenging. And in the beginning, we thought, that might have been a fluke, and then now we know it's not. There is something, that's caused our patients to just be much more severely ill. So again, a lot of this we see because we look at our trends very closely. And then next slide, please, Carmen. So again, we actually heard from our executive leadership team to look at why you have been seeing an increase of patients going from urgent care to the ED. So we had to look at our trends. We had to look at some of why this was happening since October. And we did see that since October 2023, we have seen a 28% increase of patients being referred from the lobby.
To the ED.
To the ED. So this is patients you don't even see here in the back clinic. From the back clinic to the annex, it's been very consistent. So 6 to 7%, which means it's just, we know that patients come to the back, you as providers evaluate them and determine, you really need to be an ED patient, that volume has not changed. The out of network patients, since that's something that we did work on recently, we have seen also that there's been a 13% increase since April 2024. So for those of you that are paying attention to dates, April 2024 is when.
We started the MS.
Correct.
Out of it. So that's the number of people going to the ED.
Correct.
Instead of out.
I
So
think, Merjo, just to clarify, I think it's just 13%, not necessarily an increase. Is that right?
13%.
Are these the people that were, instead of sending them to the outside clinic or in their network, they're too sick and we send them to you?
So it's a little of everything.
Yeah.
So I'm just sharing with you guys the numbers. So in order to dig into that, we have to actually do chart reviews, right? Because there are absolutely appropriate patients that we are sending over there.
I don't understand something. Did you say that since January 2024, there have been more transfers from the urgent care to the emergency room?
Correct, because
Period, but most of them are coming from the lobby, because if it's 6 to 7% consistently from back here, it's not a clinical
correct.
thing. It's something to
Yes.
do with who's presenting in the lobby, right?
Yes, so correct.
Okay, I just wanna make sure, because it makes it sound like we're
Diane,
sending
Diane.
more people,
yes, correct.
but we're not. Because we're so good.
Okay, next slide, please. So as Diane mentioned,
There
we
you
are
go.
looking at what is going on. So we looked at our data since this was brought to our attention and since we saw, okay, 28% from the lobby, what is going on? So we looked at the data from March to May 2024. And we actually, and the lobby nurse is gonna test to this, when we realized that much of the volume was coming from the lobby, we updated our tally, our daily, for those of you that aren't aware, we have a daily tally log that the RNs keep, a daily manual tally of how many patients they actually send to the ED. We can actually technically run a report of how many of those are that get sent to the ED, but they do a manual tally just so that we have real-time data on a daily basis to get a sense of what the flow is in the campus. So when we looked at that, we realized we have to be able to look at the charts, just like what Annette is saying. How can we determine if the patients are appropriate that we're sending over there? And so we asked our lobby nurses, please put the MRN so that if we had questions about why did we have 15 transfers to the ED on this day, that we can actually look and make sure that they were appropriate or if there are any trends that we need to be aware of. So we did see we saw variations in the percent of ED transfer thresholds by lobby nurses. So part of our countermeasure for that is really to meet with our lobby nurses, in the next few weeks or months, and just really looking at standardizing some of those thresholds. We've also, however, truly seen a reported increase in chest and cardiac complaints in the community. And if you see here, that chest pain is one of the top chief complaints from the lobby that's being transferred to the ED. When we reported this up to our higher ups, our director of specialty care, Rosalie, actually piped in, because we wouldn't have known this information, that they have also seen a higher percentage of visits and requests for our outpatient cardiology specialty team. And maybe Teresa can speak to what is going on in the community in primary care, but there is something that's been happening since the beginning of this year, or maybe even earlier, that
People aren't getting into primary care.
Okay.
what it is.
So Diane's
COVID.
but there have been higher chances, things happening with that. So it's very possible that because we're capturing that at the lobby end, and that is why we're seeing that. But again, we are looking at that closely on a daily basis. Next slide.
I would love to know the breakdown of the patient type that's coming in with chest pain, right?
Yeah.
Is it people that are not engaged in primary care? Is it young?
Yeah.
Is it old? Is it, all
Is
these
it,
types of
and
things?
what are the, is it, what's the chest pain? Is it cardiac or is it
Right.
anxiety?
Right, and the age breakdown, all that would be
Yeah.
super interesting to know.
So, yep, again, now with the MRNs, we're able to kind of look at that a little bit more closely if we really wanted to look at the trends closer. So to Annette's question, So the back clinic to annex and ED transfers, we've been looking at the data from October to May, because we have, we can collect that data much easier. And we did look at the most frequent chief complaints, and it's not a surprise, abdominal pain, of course, is high on the list, but you all probably know abdominal pain is one of those very complex things that need a lot more, et cetera, et cetera. So those we know, but then that is something that we will probably look at more closely. We also have seen, some variation in the thresholds of providers of transfers to the ED. So we will look at that closely, and when we do look at transfers to the ED, we part of the chart review is to look at were they appropriate or et cetera, et cetera. And so your documentation actually is very important, because when we talk to you about these patients, we sometimes will say here that, I blah, 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 the patient presented with such, and if it's not seen in your documentation, then we won't know that until we talk to you. But
Can I just interject?
Yes.
Wow.
We end up,
Karina, keep it down.
Yes, Karina.
thank you. Anyway, I do have a question, because we are MSEing, or some of us MSE more than others, patients out. There has to be some sort of provider documentation regarding these particular, like chest pain, abdominal pain that we see more of, that definitively indicates it's non-acute, and we don't need to jump all over it, because God forbid someone walks out and collapses. So I think that I'm not sure exactly how, going back to MSEing and out of network with someone of that pain, or a pain of that, that's not an acute appendicitis and something that really needs to go over. And we're because some things don't appear as that acute, but could be brewing. I'm not saying we should concern ourselves on every patient that way, but I'm just curious also how to document some of this so that we are not running up a legal trail here ultimately at some point, because the triage did their job. We're seeing the patient, we're documenting they're to go somewhere else. And if they're out of network to some urgent care outside, and they don't go, or they can't get an appointment, or, maybe I'm just being devil's advocate here, but
I think that we're pretty good at assessing a patient, and if they're out of network and there's something acutely going on, people are conscious of, the question is, we'll send them to the ED, right?
Yeah.
And that's part of why we're talking about it right now.
right.
Because we have a lower threshold now of sending some of these out of network people to the ED.
Yeah, because we get a lot of these abdominal pains. A lot of them are just kind of anxiety. So it's chest pain.
When we first were doing this, everybody was like, I'm going to be sending everybody to the ED, but I don't think that's what's
No,
happening.
I don't think that needs, and I'm just curious, like how much documentation in the note of an MSE should be there.
Whatever makes you comfortable.
Carmen,
So hold on a second, I can answer that a little bit and address it. I think, Karina, you bring up an excellent point, right? Because we are really judged and evaluated by our documentation, right? And first, I want to remind everyone that when you do a medical screening exam, it's kind of how you assess the patient at that moment. And you're right, there are going to be the times where somebody starts to crump afterwards, but when you saw them, they weren't in a situation of emergency medical condition. And I just say, you do what you can with what you have, and that's actually what's expected, the minimum expectation of an MSE, right? So I think that's appropriate. As far as the documentation, you're right. I think that something that we need to start to think about is how can we optimize our documentation so that people really understand this is what we saw at this point in time, right? And this is the rationale of why we sent this person home, or why we sent this to their in-network urgent care, or why we sent this person to the emergency department. And maybe that's something that we can work on, is to standardize some of that language so that we don't have to keep guessing and pretexting every time we do it, like maybe a smart phrase that will, again, standardize that communication.
No,
So
and I
again,
agree with that. I think a lot of it too doesn't always sit on a smart phrase. It has to be documented, but you want the support of the institution behind you in your decision making and that you write it accordingly.
Absolutely.
And I'm just saying that I'm not saying it's, 99% is probably fine and that 1% we don't know. So it's just something that I brew over a bit at times because I do a lot of it and it's fine and I trust my own judgment. But it's just something to think about.
And Karina, just to assure you, absolutely, your documentation, and that's one of the reasons I said that reminder, early on, that as long as you guys document your thought process, that is something that absolutely we will stand behind. And that's
Okay.
why it's even more important that you do document it if you thought it, because sometimes, what we find is, you thought about it, but somehow you remember the patient and you recollect the patient, but somehow it wasn't refreshed or whatever, not seen in the documentation. And that's where we get into trouble with not being able to speak to why this situation happened. So, but we absolutely, anything that you guys think we can do better as far as putting systems in place to make it easier to remember, how to document, when to document, please let us know. Because
I'm having been in depositions before. They're very particular on what's said on even in this small context.
Exactly.
Short context and not full note per provider as to why that wasn't written and stuff. And so I'm mighty aware after sitting through those that, what they look for.
Brooke, did you have questions?
I was just thinking about the MSE note I feel like I shy away from getting more like templating in. I feel like just like freehanding, sentences that are just like, this person deserves a scan, sending to the ER is the most clear language, or, because this abdominal pain has been going on 6 months, it is not urgent, therefore, but like you can write, we give return precautions, like all these kinds of things. But it just seems like a really short, succinct pretext is good.
And I think that's actually a great practice. Like when you're talking about out-of-network patients, where it's not like you're transferring them right to the family health center and they're like, or RFPC and they're right there. And I agree, like we actually need to put a little bit more information in those MSE notes for out-of-networks. Again, what our thought processes, what our rationale for discharge or their disposition, I think that's crucial. So maybe that's something that we can build in at least to the template to kind of remind ourselves, let's add that extra information.
Okay. Great. Thank you guys.
Thank you. Well, anyway, that was my little.
Okay.
Thanks, Karina.
Thank you, Karina. Okay, next slide. I think is this. Okay. So out of network to ED transfer. So again, you guys brought it up actually. So we did look up the data collected from April to May. And this is just food for thought, nothing that really that we wanted to speak to, but a large percentage of the chief complaints that we've seen are mainly musculoskeletal.
Really?
So a lot of,
Would that be,
type stuff.
I was gonna say that somebody who's out of network, who's
Right,
got a broken
exactly,
bone,
exactly.
then
That
they
we're-
need to be.
Correct.
Okay.
So those are the ones that we're sending mostly to the ED that are out of network. The rest of them are
That seems
right.
Yeah.
And the abdominal pain we already talked about, those are some of the
Skin problem.
So the rest of the other ones probably shouldn't, the numbers are so minimal, it's not really something that we thought would be
That's like one
mentionable.
But
Does it ever happen when you go back to look that you see that they weren't actually referred? Because sometimes I've seen patients
Refer.
Like that we didn't tell them to go.
Oh, I see. No, these are actual ones that we transfer. So when you guys dispo and then your dispo that you choose on Epic is to transfer to ED.
Got it.
Yeah, so there is a process when we refer patients over there and the ED questions them, that process that is not this. Because those get reported to us in the leadership team process. Does that make sense?
Yeah.
Okay, so
Earlier,
this is mainly Epic report data.
earlier you used the word, we look at it for the appropriateness of, you said appropriate for us transferring to the ED. Do you base that on our exclusion criteria? Or is there another rubric we look at to think of appropriateness of transfer?
So if we were to actually do a data, like a chart review of all of this, we would have to pull all the MRNs of the musculoskeletal
Yeah.
pain. And how we gauge for appropriateness is not through this report. Because we would have to look at every chart individually. It is very labor intensive when we
Yes, I
try to
imagine.
collect that data.
I
So
don't even just mean
Yeah.
for the out of network, I
Right.
just mean for us to know if our clinical decision making is systematic, prudent and sound. Would we use the rubric of exclusion criteria?
correct, yes, and also some of your evaluation.
Okay, so
process.
something about our
So,
note or
yes,
workup,
Correct,
okay.
correct. Is it that right, Teresa?
Yeah.
That's what we would look
Okay.
at, exactly. And I'm saying, I'm looking at Teresa because it wouldn't actually, like, I would not be the one looking at your chart to review for
Okay.
providers. It would be our provider leadership team
Okay.
that would do that. Does that make sense?
Yeah.
When we're looking at data from the lobby and the nursing decision making, then yes, myself, New and Amy will have the licensing to look at that, but I would absolutely not want to guess that Annette made the right decision. Teresa or Carmen or Tanya would be the ones to look at that. Does that make sense? I want to
Yeah, it
just
has to be-
assure everybody that
Yeah,
we absolutely, work within our.
yeah, it has to be holistic.
Correct.
Some of it is, what
Correct.
are the vital
Right.
signs? What's the nursing note? What is the
Yeah.
person there for? What did you document in terms of your exam? So, because you can't just go on one.
Yeah.
Yeah. So I think Renee had a question. Did we pull out the data in patients that are returned to ED that are out of network?
What is, huh?
What do we care
Do
about?
do you mean that patients, Renee, do you mean the patients that go back to the ED from here?
From ED to lobby back to ED, I think. The lobby.
It sounds like the ED is a screening.
Sorry,
number.
I'm here.
Sorry,
I'm,
is that- do you wanna
Yeah,
clarify?
we don't.
yeah, so my question is patients not from return from the lobby, but patients that are ED follow-up and make it through the lobby because they like, oh, the one we had the other day was a patient, like I was riding my bike and I got bonked by a car and fell off my bike. And they went to ED and ED sent them to us and we're like, well, they need imaging. They got knocked off their bike. And
So
so we
that-
sent them back to ED, but from back clinic by a provider.
So are you asking where that data would be captured? So yes, that would be captured in that report that we saw. But we do look at patients that are going back and forth between the ED and whether it's us sending to them and they send back to us. So we actually look at that also. So that is a separate quality thing that we do with the ED leadership team. Like I said, we meet with them on a monthly basis. So we have actually an ongoing running discussion about back and forth when we have patients that bounce back. We call them bounce backs. And part of that is us as a team being able to really look at the language and scripting between our teams to make sure that we're not putting the patient in between, a flow issue between our departments. So I guess to answer your question, Renee, yes, we do look at that data. Some of that data, as you mentioned, might lead into this additional report. But if we wanted to look at bounce back very closely, we would look at the data in a different way.
What's the
Yeah,
average?
because I'm just asking if this is like a carve out from within. I know we measure
Yeah.
bounce backs from the lobby and from back clinic, but I'm asking like patients that are ED referred who were always going to be out of network for urgent care that end up needing to get sent back, essentially with that lower threshold applied.
Oh,
If that's a
see what
separate
you're
data
saying.
metric.
So part of, I think, so I wanna, you're Renee, so that, if the ED did the same thing that we are doing, it would be ideal. I think, we actually have had started the discussions with the team. Part of the reason that New and Amy presented what you all saw and got presented to you when you were educated about the MSE process, we actually made that exact presentation in a smaller, like a more concise version to the ED leadership team. And we have also presented it to the ED triage team. So we have just started that process. And part of the reason that we wanted them to see what you guys learned is because we would like them to look at their own workflows and see how they themselves can use the learnings that we've made and maybe look at how they can use that for their own. You know, that obviously though is gonna be a much larger endeavor. And Annette can probably speak to this very easily because she knows some of that, but to educate if you can imagine the amount of staff meetings we have had. And we try very hard to communicate with everybody and talk to everyone and do our best. We made an effort to train 100% of you guys, 100%. We captured you if you were on vacation, if you were on leave, you got training from new and Amy. And we still have so many questions and still so many things to make better. So multiply that to a larger ED team that is just, there's just so many more things going on there that you and I cannot even fathom. So they will absolutely, if they decide to embark on this, will go through that. And I cannot imagine how easy that would
I
be.
just want to say how grateful I am for the process. I think it's great that we're doing this. It is
Yes.
so appropriate. I mean, we need a single payer system for sure. And this is
Oh,
a
yes,
huge waste of
absolutely.
time on so many levels. But it feels so right to like guide people towards their correct health institution, you know, healthcare place. And so I just really appreciate that we're making the effort and hopefully really be able to have more space and availability to our in-network patients. I have one question is, I know we know on average how many people are referred to the urgent care from the ED, right?
Urgent
There's-
care to the,
Like on average, how many is it? And can we communicate with them on these days when there is very low staffing?
oh, yes, they know,
Because
they do.
Who's
So-
those
so
at?
part-
Us or them?
we,
Okay.
like
that's
tomorrow
fine.
night, I'm gonna be here and there's one other provider.
Yes.
Yeah.
And
So-
I don't wanna have an
so-
onslaught of ED patients.
So they absolutely do actually know.
Okay,
Diane, so just so you know, and part of the reason that the lobby team sends me the report at night when they end is because before 7 o'clock in the morning, part of the report that the charge nurses send to the ED, which is they report how many patients were seen by urgent care and how many were from the ED. I reply to that message and the charge nurse is gonna reply and speak to this. If we have any, even one provider sick call, they get a report of this embed report.
okay.
And if there is a day like last Saturday? Like it was one of the Saturdays this last weekend where we had like 3 providers or something. Even Teresa gets an email, a text on a weekend. That there is a staffing, and it's specific to provider staffing, Dee, because
Yeah, totally.
as you're aware, our nurse staffing is just much more robust
Yes.
than our provider staffing.
Mhm.
Not for lack of us working on it, it's just, it's
Yeah.
much harder to recruit providers than it is nurses. So, we absolutely, your leadership is aware. That doesn't absolutely stop any of the frontline staff from still complaining, because my guess is if we are short here and our flow is high, that their flow is also high. And you know, it's not because they're maybe not aware or don't care. It's just people are frustrated. Whenever there's frustrations,
Yeah,
you know, things come out. So, but if anything inappropriate ever happens, please let us know. We will absolutely bring that to their attention. That's part of the reason that we are working on how to improve teamwork between us and the ED. Because we absolutely want to remind everybody that we are a team. When we're short, they should know. When they're short, which is most of the time, we do know.
yeah.
So we do our best to help. And so we are here to work together to.
We're all trying to do the best. we
Correct.
can.
Yes,
Nobody's
absolutely.
trying to shit on anybody else, you know,
I feel
so.
like we should have more face time with them.
Yeah,
I'm
we
like,
should.
sure, I mean, probably I know Annette says no, but. Not to be like,
recorded.
not to be Pollyanna, but I just feel like if they all saw that we were smart, nice
Humans,
people,
yeah.
and saw that they were smart, nice
Yes,
people, we would
absolutely.
have more mutual respect and realize we're trying to do the same thing,
Exactly.
you know?
So part of the reason that we've actually started like presenting to the triage team and things like that is absolutely for that reason. So for those of you that remember this, when we first started the lobby triage process and we were working on a lot of PDSAs with the ED, part of what we did to really kind of cement the fact that they had to call us was to work with their team very closely. So part of that, what we ended up doing at that time is I would actually daily round in the triage area. We also invited their charge nurse and nurse manager team to our charge nurse meetings, and vice versa. We would attend the charge nurse meetings to really help kind of, again, solidify this, that we are all a team. That as Diane mentioned, we are all doing our best, but there are days that we are short and there are days that just, you know. So you're right. I think part of it, and then that's part of the reason why we're bringing it up to this group, because we want you to understand that we hear you guys. We're hearing a lot of frustration from our lobby team, from our charge nurse team, from our providers, that we're getting a lot of back and forth with the ED team again. And again, we're also hearing from them, and we're hearing from them, you know, blah, 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 that the lobby team's doing this, that providers are doing this, blah, blah, blah. And so I think part of it is just that reminder, I think is helpful.
The ED's got to release, they've got to release, this is a game changer. I don't know if it was Merjo, I don't know who initially, morning everybody, this is Christina. I don't know who initially the idea was, but even the thought of our health system getting a chance to just take a little bit of a deep breath, just a baby deep breath.
Yeah.
My God, this is a game changer. They've got to give up whatever type of, when it's a system-wide game changer situation like this, the ego's gotta go. The ED's just gotta stop. I mean, because if they adapt this, the whole system will be able to feel a deep breath. They gotta stop. They just gotta stop. That's it. Love y'all.
We appreciate that. And so I want you guys to assure you guys again, like you guys said, your efforts are making such a huge difference. Not just for the patients and the patients that we see and the least of complaints, but like Christina mentioned, we hope the stewardship that we are doing for this will help our patients. Because again, we're not turning away patients that don't have coverage. That is not what we're doing. We're sending them to their providers. We're sending them so that they can be linked to their primary care doctor, for God's sake, so that they could get that whatever stomach issue monitored more closely and not be patched by an urgent care visit here and there. So, you know, thank you for bringing that up. And so the next steps, I want to just be mindful, we have 2 minutes. So our next steps is really, we want to know from all of you how we can continue to support you in optimizing how we transfer patients to the ED and vice versa, and how we can continue to improve our out-of-network workflows. And you guys have mentioned some of that already in the chat and questions, and you guys continue to let us know that, especially the charge nurses, when there are issues. So we appreciate that. And just so you guys are aware, potential countermeasures that we're gonna probably look at based on some of the chart reviews that we've done, and then just looking at the data between the ED and urgent care is really looking at chest pain protocols for the lobby, and seeing how we can maybe tighten that a little bit, or maybe even streamline it even more. Because there are some, you know, chest pain things, like you said, someone mentioned sometimes it's anxiety related or something like that. So we want to be able to look at that more closely. Smart phrases to support effective documentation. A lot of you have already mentioned, thank you, Karina, for, you know, just how important documentation is. Ongoing clinical education, that's always, you know, something we're always going to be learning. And again, chart reviews is something that we do between our departments. And we will be looking at the outer network specifically, as Brooke mentioned, if we wanted to glean more learnings from that. And then urgent care, remember, the ED is one of our strongest stakeholders and also one of our strongest partners in all things, actually. So do understand, we are going to be continuing to collaborate with them and working with them. And that is one of the reasons that we always appreciate you guys letting us know and giving us feedback. But we will absolutely take your recommendations to heart. What can we do to build better, stronger relationships with them? Whether it's possibly inviting them over to to get to know our workflows a little better, or at least specific stakeholders and vice versa. And then I said, shook her head, but that's still mine.
You don't know, Dan.
Grain of salt. Okay, yes, ma'am.
But one thing I've been thinking about is what hurts me deep inside is when I send a patient to the ED and I see them up on the track board. For example, I sent a pregnant lady who was in for severe pelvic pain. She was pregnant, she was here to the US from 2 weeks. She had severe pelvic pain. It started last night. It was like 7:30 p.m. She'd never had an ultrasound. Like, she needed to go get an ultrasound, right? And so anyway, and then when I look up on the board that she got to the ED, it says flu-like symptoms. And so and that is like just an example, but things like that happen all the time, where then I look at the board and the note, and I don't know where the miscommunication happens. Is it when the nurse walks them over, something is lost in translation? Is it in urgent care when I tell the person why I'm sending them, or tell the charge why I'm sending them, or is it happen over there? But then that patient, she ended up left without being seen, you know what I mean?
No.
You know, and that was just like one random example, but like then it feels like it happens all the time, where I'm like, that is not why I sent them. So I'm so curious, like when they hit to the door, do they read my note?
No.
Even if it's just the MSE note, or my excellent already workup of like, I have been over sending people. You know what I mean? I'm like this, I ask 5 people before I do. Like, I try to do all the things we can do.
Yeah.
And sometimes I get over there, I'm like, oh my God, I did not send them there for dizziness at all.
Yeah.
You know? And so
So to assure you, Brooke, so when we send the patient to the ED, the charge nurses actually have access to their track board to put them on track board. In
Yes.
fact, that's actually standard work. And so in that opportunity, that's where we have a line or something where you can actually, you know, put there the transferring reason, and they absolutely see it says UCC transfer. But to your question about how much further they dig back, so I'm going to say, having worked with the triage team now for at least, you know, since October, some of them will look at your notes, and some of them absolutely won't. And some of it, that's true. So some of it is just the difficulty of having to go through the outpatient track and whatever, and some of them have a belief that why would it matter? I'm going to ask them in triage. We have specific protocols in the ED, and we're gonna just do what we do for that. And that is so I think
It's a flow.
it's a flow thing. So I think ideally, and that is one of the reasons I think that we brought up to this leadership, that, you know what, you guys have to, in part of efficiency is being able to work with one of the biggest teams that you work with, us, and knowing that we already have a provider that absolutely took their time to document MSE, whatever. What can you guys do to streamline your process so that you can build on what we did rather than start over? Because that efficiency, I think, is a large thing that people are, that at least that partner of ours is not fully utilizing.
Or here's another example.
You know what I mean? Like, does that make sense? Like,
Yes,
I think that just like we build on primary care and we look at absolutely, why did Teresa refer? We have to be able to do that. But in fairness to them, us looking at Teresa's notes in FHC, it's much easier than the ED looking at our notes, because it's actually a totally different interface. Just like why you can't see inpatient documentation very clearly. You might see there was an admission and you might see admission notes, but after that, you're doing black hole until maybe later. Does that make sense? So there is an epic interface issue. So I want, and that's why they oftentimes will order the same type of CT scans that you did or whatever, because they won't even know where to look, that you did an outpatient radiology, anything. And it's not their fault. We're not saying it's their fault. It's just that there are limitations too, because of the flow and their pace, and God knows what else is happening with staffing, and maybe they're short staffed. So all of that. Does that make sense? So maybe there is a paper version that we should be doing instead of in order. I'm not saying that, please don't say, but what I'm saying is maybe there is something that we can do that is better than Epic, because right now that doesn't seem to be.
Because they're wearing a green bracelet, are they isolated, like they go next?
No, they just go to the waiting room. the way to
just
say
know they
it.
came from urgent care and that's all that means.
Yeah, I'll say on the chalkboard from UCC and then their green bracelet, and then that is their trigger that they know that it's
I
specific.
think the city that also just needs a reminder, because when we started that UCC referral, they specifically told us what they wanted to put it there, like what tests were done, what imaging.
Right.
They said that?
Who said that?
It was some email, that's why I said, I'm not quite sure.
Because
There
when
was-
when a complaint walks in the
No,
door,
it's
there's
part
a
of the
protocol
workflow.
to follow. You don't need
Yes.
to tell them what to do.
Yes,
There's
exactly.
a standard of care.
Yeah.
Yeah, there is, correct. So
I
we just.
guys, I can speak to this a little bit. So
Mhm.
the ED, you guys know they see 1,000 patients, and Merjo, your summary was really good. But there's a couple things. Like one, when a triage nurse is trained how to do an ED triage, they don't care where they came from. They don't care if they walked off the street, they were sent from Tom Waddell, they were sent from us. They don't care. They apply the same process every time, and
Yeah.
it works. That's why they have a system, right? So they ask the patient, "Why are you here?" They don't look in the computer and say, "Why did urgent care send you here?" And the patient can say whatever they want, right? Sometimes a patient came to us for hand pain and they're in florid alcohol withdrawal. We send them for alcohol withdrawal. The patient tells the ED nurse, "I came for hand pain." That ED nurse is going to put hand pain in the chief complaint. And what happens is that the way that they see it is that when we look in the ED care timeline, we can see like updated notes. They don't have that. They actually don't even have that part of their epic. So when the triage nurse writes hand pain, whatever we wrote, like alcohol withdrawal, is gone. It's gone forever, essentially, for them. And all they ever see on that patient's board up on the computers on the wall says hand pain. And so there's a major systemic issue. Like they're standardized for a reason, and it largely works. But we're kind of falling into this hole here with them.
Right.
And then their epic is not compatible very easily with ours. It is not part of an ESI ED nurse's triage process to read clinic notes from earlier that same day. And those notes don't get populated into their notes either.
Yeah.
So they don't often see them. They really don't.
Yeah.
It's not that they don't mean to, but every patient who walks through the front door is equally as sick, and they have to follow their process or else they'll miss something. And so we can try to find a way that they can still see our notes, and that's an epic thing. It's not for lack of intention, but they're just doing what they are trained to do, because that's what keeps the most number of patients safe for the 250 a day that they see.
That's why I think, Renee, like I mentioned, part of our discussion with that leadership team is, and why we're sharing our workflows and why we presented what we presented to all of you, is we want them to come up with whatever or even just to realize maybe they can build on what we're doing, and how can they do that? Because you're right, the workflow that they're doing is their workflow because it works for their department. And we are in no whatever, just like we don't want them dictating our workflow. We don't know. Maybe the answer is they still won't look. I don't know, but we have to at least let them know, so that they understand our workflow, so that maybe, a light bulb will come up, and maybe someone will go, you know what, maybe we do X and it would actually streamline something. But again, we have to work with them on that, and part of why it's so important to have a team like ours to be able to come up with ideas and try them and put it back if it doesn't work, and put it back if it doesn't work, is because we know that you all are the experts on what we can do better. In fact, I think someone from our team a few months ago mentioned, hey, why don't we do for out of network what we did for FHE and 1M, and look where we are now, 2 months later. So again, because of all of you, this works, and we want to just appreciate everybody for all your hard work. We hope that a lot of what we're saying will resound with the ED team, and that it can get better, and so we will stay hopeful. One thing I want to be mindful, it's like 9:09, so I just want to make sure. Last comment from Roca.
I just think that when we have this conversation, it's very top heavy, talking about how it affects us and how we feel about it. I think maybe we would all be on the same page, all the stakeholders, if we talk about, like, are there bad patient outcomes that happen because of these about communications? And it doesn't have to be someone died in the ED waiting room or someone whatever, but just like if patients if they looked at were able to see our notes faster, would these patients get a sooner evaluation than other patients? Like, if we could come up with some patient-centered metrics, I think maybe that would get everyone on the same page, because now it just feels like I'm saying, like, they didn't read my note, or they didn't validate me sending them to the ER, so maybe we need it, like, our mutual thing is we want to give the best patient care, so what are the outcomes for patients? Would be a way to approach it.
Yeah, thank you, Merjo. Okay, thank you, everybody. We apologize, we went over. Thank you.
Thank you.